I'm Dr. Danielle Goldfarb. I'm a dual-trained neurologist and psychiatrist and memory specialist at the Banner Sun Health Research Institute in Sun City, Arizona. And I'm very excited to talk about early diagnosis of Alzheimer's disease. There's been such a change in our advances in our understanding of Alzheimer's disease on a neurobiologic level, and this is directly affecting our clinical care and diagnosis, and we'll talk about that today.
And hello, I'm Dr. Anna Burke. I'm the director of the Alzheimer's and Memory Disorders Division at Barrow Neurological Institute in Phoenix, Arizona. I am a geriatric neuropsychiatrist, and I am also somebody who cared for two grandparents who suffered from dementia. So I feel very passionately about this particular topic. It is one of the reasons that I went into this field, having seen how the care that was provided to my own family was insufficient, and hoping to change the way that we provide care for our communities, for families who are struggling with this disease.
With the advent of the amyloid PET scan and our ability to detect neurobiologic changes in the brain with Alzheimer's disease, so amyloid and also tau more recently, that has led to a change in our diagnostic criteria for the stages of Alzheimer's disease. In 2011, the NIA Alzheimer's Association Diagnostic Work Group added a category for preclinical Alzheimer's disease. And that is when a person has no cognitive impairment, yet we can identify those Alzheimer's brain changes via different neuroimaging or fluid biomarkers. Next category would be mild cognitive impairment, which is when there is some cognitive change, more than we'd expect for one's age, but still functioning independently. And then the third category would be Alzheimer's dementia, and that is when there is enough functional decline to affect the person's day-to-day life. Over the past 10 to 15 years, we've learned that Alzheimer's changes in the brain start building up even 20 years before there are any symptoms. And that creates this window of opportunity where we can diagnose the disease even before there are any symptoms or when there are subtle symptoms. And that can give us the ability to change the trajectory of the disease for the person affected and also for the family and caregiver. There is not yet a universally accepted concept of what defines early, or some say timely, Alzheimer's disease diagnosis, but early, for the purposes of this talk, would be considered before there is dementia. And so this is a stage where we might need to look at biomarkers if the cognitive changes are subtle. So that's preclinical, meaning no cognitive impairment, perhaps subjective cognitive decline, or mild cognitive impairment. Now, in the literature, primary care providers often might define earlier, more timely diagnosis as when their cognitive change is actually impacting their life, and that could even be in the mild dementia stage. This is where our field is becoming much more complex, and there are more uncertainties now. And as clinicians, we are trying to combine the clinical symptoms of the person in front of us. And those include the cognitive changes, the functional changes, also mood and other non-cognitive symptoms like gait and motor impairment. We are incorporating that with the biomarker evidence and trying to define where they're at in the trajectory of disease to help us best determine how we are going to approach their care.
One of the challenges that we've been facing as a community, as a dementia care community over the years, has been the fact that we really don't have a single test that we can do, right, to determine what type of dementia somebody is dealing with, what type of cognitive impairment somebody is dealing with. How do you feel that our new technologies, like some of the biomarker testing, are going to impact our ability to make accurate and timely diagnoses?
This is is absolutely being changed by our new technology, certainly. And I'm sure you're experiencing that as well. And we know that even up to 2/3 of individuals with dementia are never diagnosed. Yet that is going to change, or could potentially change rapidly. So what we're able to do with next tier of diagnostic workup is we might do some functional brain imaging with an FDG PET scan, which is typically covered by insurance in these kind of cases of dementia or cognitive impairment of unclear etiology. We could do CSF testing to look for the Alzheimer's disease biomarkers. We can do that in the clinic. And in terms of, that does often give us a lot of information to identify, is there underlying neurodegenerative disease patterns? Are there network issues? And that gives so much important information, and that absolutely is going to change the plan of care. And to be so specific is such a change for our field. Even 5 years ago, probably we weren't doing this as much, and it wasn't supported. And so this is an important message, I would say, for primary care providers and families and patients as well.
And I would add to that a lot of these newer technologies, especially the biomarker studies, are becoming more user friendly, right? So up till now, if we wanted to bolster a diagnosis of Alzheimer's disease with biomarkers such as amyloid and tau levels, we would have to do a lumbar puncture and CSF studies, or a patient would have to pay for a $4,000 amyloid scan, right, of the brain. But now we are starting to see that there are technologies such as blood tests, assessing for these pathological proteins, if you will.
Dementia and cognitive impairment of older adults still remains underdiagnosed across the world. And almost 2/3 of individuals with dementia will never be diagnosed. This is even more so perhaps in low and middle income countries. There are numerous barriers to early diagnosis of Alzheimer's disease and even diagnosis in general. Most patients are ultimately going to be diagnosed by their primary care providers. And studies across the board show that primary care providers often don't feel they have the time, they don't have the training and expertise, and sometimes lack the confidence to pursue that route of diagnostic workup. Sometimes patients, families, and physicians don't feel that, they just think this is normal aging. And as well, there's not reimbursement for the time to talk about and approach this topic. So again, if you're seeing your patient, you've known them for years, you notice they have a little bit of cognitive change, they're alone coming to their annual wellness visit, they're not complaining of it, you haven't heard from their family that they have any concerns, and they seem happy, so why, the thought process understandably is, why would I go there? Because there's no disease modifying treatments yet. So we have symptomatic treatments, but there's sort of a nihilism about it. And so maybe let's just wait and see how things unfold, because there are times when a person does have a small, mild amount of cognitive impairment, and it really doesn't progress. And recently we've learned there are these pathologic entities that are Alzheimer's mimics. And interestingly, we now have more technology to try to identify those and distinguish those from Alzheimer's disease, which will progress more consistently over time. So other barriers to diagnosis of early Alzheimer's disease would be perceptions of stigma and discrimination, and especially in someone who's still working, they're still of an age that they're employed. There is understandably concerns that this is going to affect their employment status, their ability to drive, their ability to make their own decisions. Also, there's a lack of resources and support in general. So making a diagnosis isn't just about telling the person they have the disease, especially when it comes to this slowly progressive illness that may go on for many years. So the primary care physicians have stated in many studies and surveys and that there is not the support available. And so when you make that diagnosis and you don't have that that comprehensive care, then you're actually maybe doing the person a disservice. We do not have enough Alzheimer's or memory specialists to be the only ones diagnosing Alzheimer's disease. And so primary care providers are really going to be the ones doing this the majority of the time. One study showed that half of PCPs reported the extent to which they keep up with new developments in dementia care as only a little or not at all. And also the same study said a sizable proportion of these primary care providers noted that they are never or only sometimes comfortable making a diagnosis of AD dementia. So 39% of those providers and more than half acknowledge that local specialist resources are insufficient to meet patient demands. There was a study of general practitioners in Europe assessing their attitudes towards early and pre-dementia diagnosis of Alzheimer's disease in 5 countries, which included Spain, Sweden, Germany, Slovenia, and Netherlands. And in these structured surveys, there was generally a positive attitude towards early diagnosis, with 74% stating that they thought that diagnosis in the very early stage or before dementia was of value, and there was a benefit more than a risk. So 58%, a little over half, thought the benefits outweighed the risk of having that diagnosis, which is still, is slightly higher than half, but there still was a sizable portion that felt that the benefits equaled or were less than the risks of having that. And then in terms of the benefit to relatives for their person to receive the diagnosis at the early stages, did feel that 71% felt the benefits outweighed the risks. And then the question of, do they feel confident in the diagnostic procedures for very early dementia or MCI? So only 44% said they do. And I think going back to the question about benefiting the family, this is a common theme throughout all of the literature and surveying family members and patients. And there's a sense by physicians and family members that they want to protect the person and maybe withholding that information about what actually is going on with them. The diagnosis is in it. To them, it's caring for them and protecting them. Whereas when patients are surveyed, they individually want to know what's going on with them. Dr. Burke, when you're working with primary care providers in your hospital network, are there ways that you feel have been beneficial to help support them in their role with their patients?
Yes. So when we work with our primary care colleagues, we've noticed several issues that you touched upon in your discussion that really affect their ability to care for these patients, to identify these patients, and to bring them to us as specialists in the early stages of illness. One is time. On average, the primary care physician has anywhere from 7 to 10 minutes to spend with a patient. And oftentimes they're really focusing on a multitude of different problems, everything from treating their high cholesterol to their diabetes. They kind of see that there's cognitive impairment in the background, but like you said, they have this nihilistic attitude and this fear of opening up Pandora's box without necessarily having the tools that they need to be able to treat that patient. And we really try to change that through some of the education and supports that we provide for our PCPs and our family medicine colleagues. First of all, providing additional education about appropriate diagnosis, tools that they can use easily in their practice, something that doesn't take too much time, but will at least identify the patients that maybe need some kind of specialty assessment, even something as simple as incorporating a mini cog into your assessment as your medical assistant is doing vital signs can be enough to identify at least some of the patient population that might be dealing with cognitive impairment. And then giving them access to virtual resources or places that they can refer their patients and their families to. So once they know that those resources are available, they're a little bit more likely to diagnose and to open up that Pandora's box.
Thank you. There also are a number of efforts going on across the country which involve collaborative interdisciplinary programs between primary care providers and specialists, where a new workforce is being created, which sometimes called navigators or health coaches, that will go into the home and work with both the person with dementia and the caregiver. And that's really a big shift, I think, distinction between primary care medicine and us in this specialty role, where we view the recipient of care as the patient and the family. So that is always a core feature. And I think that is where there's a big distinction. And in it as well, dementia, having cognitive impairment or dementia really affects every other aspect of that person's care and sense of self and relationships, and how they can even engage with their treatment recommendations and other disease processes.
Right. And I do think that you also made a really interesting point in your discussion where you mentioned that sometimes primary care physicians feel like they're doing the patient a disservice by identifying this disease, like they're harming them in some way, because maybe they'll have to address taking away certain privileges like driving or financial management or some other aspect of independence. But it's interesting that we have this type of approach to dementia, which is a chronic illness that needs to be managed. But we would never think to not diagnose somebody who is dealing with cancer, right? Or who is dealing with diabetes, because God forbid we may have to talk about amputations or something else down the line. So we have to remember this is a chronic illness. And the earlier that we identify this illness, the earlier that we institute certain supports, the more additional options they may have, everything from clinical trials to some of these newer therapies that are becoming available. So we have to change our mentality of what this illness is.
What is the optimal time to diagnose someone? Is it very early? Is it mild cognitive impairment? Is it mild dementia? Is it later? So we really don't have strong evidence, high quality studies to help guide our practice. A lot of the evidence is more based on expert opinion, because it is very difficult to study these types of questions. And that unfortunately translates into a lack of guidance for primary care providers. In terms of identifying these links between timely diagnosis and improved outcomes, it's helpful to know, it would be helpful to know what are we dealing with right now in terms of who does get diagnosed? What are the characteristics of the patient population, the demographics? And that would help us better create systems that are going to, of course, have more equitable and likely early diagnosis. There was a study done through Johns Hopkins. It was a cross-sectional study of 585 older adults with probable dementia. They had access to their Medicare claims over 3 consecutive years. And what they found was that 41% of older adults with probable dementia are both diagnosed and aware themselves of their diagnosis. So 59% were not both diagnosed and aware of that. The undiagnosed were more likely to be non-white and have lower educational attainment and also less functional impairment. Those who were undiagnosed were more likely to attend their doctor visits without a companion. So that's all kind of makes sense, not surprising, but it's important to have these statistics. Among persons diagnosed, individuals who are unaware of the diagnosis are more likely to be or to have lower educational attainment and to attend their doctor's visits alone. And then individuals who had impairments in managing finances and medications were more likely to receive a diagnosis of dementia compared to those who had other impairments, such as maybe trouble with cooking, cleaning, laundry. So maybe things that didn't have as big of safety risks if they made errors. Ultimately, what has been identified is that the decision whether to diagnose dementia is very case specific, and based on that, providers' own beliefs about dementia and the efficacy of treatment, and their confidence in the diagnosis and ability to communicate the diagnosis. As well, they're looking at the patient in front of them. Does that patient have insight or awareness into their memory loss? How severe is it? And how much support do they have? As well, the health and social care system that they have access to, including diagnostic services, specialists, reimbursement, availability for psychosocial support. So that's going to play into the primary care provider's decision of whether or not to diagnose. And then the cultural norms in terms of the stigma and labels associated with dementia and how that is going to affect the person in front of them. So there's been some studies that have looked at this, but essentially the primary care provider tend not to make general statements about how dementia is usually diagnosed or how it should be diagnosed. And it's really, again, dependent on the individual in front of them. Now, this is where our advanced technologies may change that to where if we have more of a biologic definition of Alzheimer's disease versus a clinical definition, that will help create a pathway or roadmap for a primary care provider to start that diagnostic evaluation based on, say, biomarkers, which will then, in some ways force that conversation depending on what the results are. And that will also require that there are more resources and support that are approved. One of the parts of my job that I value so much, and is a reason I'm in this field of Alzheimer's, is that I try to instill hope. And so I wondered about your approach to delivering and communicating a diagnosis of Alzheimer's disease for the first time, and using that as a source of empowerment or hope versus what I think that most often is believed to be a hopeless situation.
Well, I do think that this is a chronic illness. It's important for us to be able to communicate this because most patients, most families do see this as just kind of a death sentence. Okay, I have this hanging over my head and my life is done. It's important for them to know, especially in early stage diagnosis, especially with mild cognitive impairment or mild dementia, that we are talking about years. We're sometimes talking about decades where this illness will slowly progress. And these are years where people still get to live their lives. They may need to adapt a little bit, and we as a team are there to help support them so that they can adapt their environment. They can adapt their communication strategies for family members. They can adapt their lifestyle to really live life to the fullest, to be able to enjoy the moments that they have. They also need to know that there is access to newer therapies, that there are things on the horizon, that there's research being done into all of these potential new treatments. So there is hope on the horizon. There's a lot of work that specialists like you and I are doing that will hopefully improve their lives over time.
The recent update by the U.S. Preventive Service Task Force recommendation on screening for cognitive impairment in older adults concluded that there was insufficient evidence to demonstrate the benefits versus harms of screening for cognitive impairment in older adults, and therefore could not recommend it. And so that's specifically for broad screening of all older adults above a certain age, including those with absolutely no cognitive impairment. Now, the USPSTF recommendations really guide primary care practice. Unfortunately, this recommendation was based mainly on one randomized controlled trial that failed to demonstrate any benefit or harm from screening for cognitive impairment. So it was not a slam dunk for screening generally in the older adults. But the point is more of this, there's a lack of evidence. And so we need to work to develop more evidence to help guide that. What is currently recommended for screening in primary care is to do a brief cognitive assessment when there is any evidence of cognitive concern, whether that could be by direct observation by the physician or provider, by patient report, or by family concerns. So you can imagine that's very broad in terms of at which point that may be identified by any of those entities. And if a person is going by themselves to see their primary care doctor, they could easily be well into moderate dementia before anyone identifies this, particularly with some individuals with dementia who maintain good language abilities and social skills. They could easily get by well into the moderate stage. If we're considering what are the benefits of early diagnosis of Alzheimer's disease, these could be broken into the categories of personal, caregiver, or family, economic, societal, and research. Personal benefits, which sort of fits in also with family benefits, encompass many different things. So firstly, I would say pursuing an early diagnosis or pursuing a cognitive evaluation if there are some cognitive concerns in an older adult ultimately leads to optimizing medical management. And so we're really doing a comprehensive assessment of a variety of factors that could impact cognition. So I describe this to my patients as, oftentimes you're coming in for a tune-up, and getting a second set of eyes on all of these different things can be really helpful. As well, personal benefits of having an early diagnosis is to give someone a better sense of what is happening to them. Some people are going along and they're living their lives and noticing these cognitive changes and are becoming very worried and anxious. And this is severely impacting their quality of life, their relationships. And so having this specific information really can be a relief. Getting a diagnosis early also affords one to initiate treatment. So we do have symptomatic treatments that are approved, that are effective at slowing down the progression of cognitive and functional change. There's non-pharmacologic approaches. This early diagnosis allows someone to take control of the situation, have more of a role in their decision-making in a variety of ways. In all of these areas, we talk about, if we're in an early stage, it's often about, maybe we need to adjust your system because you have some memory loss. I'll contrast that to when a person comes in later, say they're in the moderate stage of dementia, and it's actually unsafe to drive at that point. And then sometimes where you have to meet the first person for the first time and say it's unsafe for you to drive. No one likes to do that as a physician, of course, but occasionally we're in that position. So if you're coming in early, it's less likely we'll have to do that, and we can talk about this and adapt along the way as your cognition changes over time. Getting an early diagnosis helps you plan for the future in a number of ways. And also, there's more talk about diagnosis as a human right. And some states are moving towards requiring that a physician delivers a diagnosis of dementia if there's evidence of that. And early interventions can help the caregiver in a number of ways, including understanding what's happening to their person, understanding how they fit into the equation, how they will have to adapt over time. But if by doing so, it's going to improve their quality of life, their mood, decrease their chance of burnout, stress, burden, gives them access to knowledge, education, resources, helps them have the opportunity to join support groups, become part of a community. And also potentially all of that can delay the person with dementia having to be placed in nursing home or long-term care if their caregiver has the support, education, and knowledge that they need. In terms of economic benefits, since a lot of the healthcare costs end up being toward the end up being towards the end of life and including someone having to be placed in long-term care, if we can delay institutionalization, enhance quality of life for people with dementia, and support their caregivers, that could absolutely translate into an economic benefit. And finally, research benefits. As Dr. Burke mentioned, having an earlier diagnosis gives people the option to potentially take advantage of a wide array of treatments, including many more disease-modifying treatments these days that include attacking the well-known proteins such as the amyloid or tau, but also some more novel mechanisms. And there's just so much more, so many more promising things happening now than even 5 years ago, that this is absolutely a part of my treatment plan for everyone, that I bring this up. And if there are available studies for them, I want them to be aware of that. In terms of the potential risks, this comes down to concerns that a person who has a diagnosis of Alzheimer's disease will be stigmatized. They may be discriminated against in terms of their employment, their driving, their insurance premiums, in terms of their ability to control their finances. There's other risks such as the need to continue to have repeated cognitive assessments. So essentially, the diagnosis of Alzheimer's disease has to be integrated into this person's life and identity. And for some people, the more they have to hear about it, the more anxiety-provoking it is and psychologically detrimental. There could be issues linked to privacy and confidentiality. There's a potential risk of misdiagnosis. And on that note, I would say that some of the newer technologies are helping us identify this group of older adults who actually have an Alzheimer's mimic, which is often seems to be due to a protein called TDP-43. And this group of individuals, they do not have elevated brain amyloid, but they do have a memory predominant syndrome. So they look like Alzheimer's disease, and yet these people do not progress on the same trajectory. It's more benign than Alzheimer's disease. And so those individuals would be misdiagnosed as Alzheimer's disease potentially and live their life thinking they were going to progress much faster than they actually do. And so, luckily, again, with our technological advances, that's going to change very soon. And hopefully that also drives primary care providers to want to get their patients diagnosed sooner. The best practices in Alzheimer's disease diagnosis are still under investigation. So the question is, so who should best diagnose Alzheimer's disease? Should it be the primary care provider, the specialist, both? And we know that there aren't enough specialists to go around, and so primary care providers will be those that are going to be doing the diagnosis. But perhaps, certainly when there's atypical cases, complicated cases, a specialist should be involved. Then to whom? So who should be given the diagnosis? Should it be the patient, the family, or both? Due to the cognitive impairment and maybe the lack of insight, this is what leads to some physicians and providers thinking that it would be best not to share this with the patient because they're not aware of it. And it might cause distress. So that's another question. And then when? So what stage of disease is best? And of course, in this group here, we support earlier diagnosis, but that early diagnosis again has to come with a lot of support and services, and our healthcare system has a ways to go in terms of consistently and reliably providing those and reimbursing for those. And then how is this diagnosis best communicated? So what are the components of diagnosis communication when it comes to Alzheimer's disease? What is the terminology we're using? is there provision of ongoing support and linkage to resources? And so all of these things are open for and need for more efficacy research to help drive us to an improved system. Because Alzheimer's disease is so complex, affects so many cognitive and functional systems, affects so many people, including not only the patient, but the caregiver, we really need a multi-component approach to optimally diagnose and treat Alzheimer's disease. And this would include Alzheimer's disease guideline development to provide better roadmap, pathways, algorithms for healthcare providers. This would include clinician training and education, again, for every step of the way in the disease process. This could include Alzheimer's anti-stigma campaigns, bringing in patients and families to advocate for one another. Multi-component approach to Alzheimer's disease diagnosis would include enhanced therapeutic services for early diagnosis, so things like cognitive rehabilitation therapies that are validated, that are accessible throughout, and not just in busy urban academic medical centers, but also in rural areas. Greater reimbursement would be important, and increasing access to specialists. In my practice, I counteract that sentiment that there's nothing we can do when someone has dementia or Alzheimer's, that it's hopeless, that the treatments we have are only modestly helpful and they're only symptomatic, because what we do as specialists in this field, or as physicians, when we're diagnosing, our treatment plan is very comprehensive. We equip them with the knowledge and understanding of what that means for them now and what that will mean for them in the future. And we are partnering with them so they feel supported throughout this, that we are going to, as a team, including their family members, adapt to the changes slowly over time.
I absolutely agree with what you just said. I think engaging patients early in the course of the illness with an early diagnosis, making sure that they're supported, making sure that they know that they have a team on their side, going beyond this diagnose and adios type of approach where you're just giving them the diagnosis, giving them a prescription and sending them on their way, is really the key to therapy. A lot of people feel hopeless once they have this diagnosis because they feel like they are out of control, like they're no longer able to control their lives, no longer able to control this chronic illness. Having that team on their side, being able to instill that sense of control, and you can still live your life with this chronic illness and you still have a say, that really impacts them in a very powerful way. And when they're diagnosed in the early stages of this illness, they're still able to participate in decisions. They're still able to make their needs and desires known as far as what they would like years down the line if their care needs change. I think we as dementia specialists, both Dr. Goldfarb and I, are always looking towards the future. We're always looking at what more can we offer to our patients. So looking at clinical trials, that may be an option so that they can do something beyond just the standard therapies. But I think we're also looking at how early diagnosis is going to be vital as our technology, as our treatment options improve. As Dr. Goldfarb mentioned earlier in her discussion, we have this concept now of preclinical Alzheimer's disease. We know that those changes in their brain are occurring for decades, that amyloid buildup has been shown to start 10 to 20 years before they ever have clinical symptoms. As our technologies and our ability to identify those at-risk preclinical patients increases, and as therapies become available for those earlier stages of illness, I think that early diagnosis is going to become even more vital.